Hello, everyone. My name is Dr. Kimberly Boland. I am the current chair of the Department of Pediatrics at the University of Louisville, as well as the chief of staff at Norton Children's Hospital. And we would like to welcome you to our COVID-19 pediatric update today. We're very happy that you joined us, and hopefully you will find this as informative as I have, just being part of it. You will receive a link following the program for evaluation, or you can use the QR code display in the opening slideshow to do your evaluation and get your CME credit. I would like to start by introducing our panelists. First is Dr. Kristina Bryant. Dr. Bryant is the Medical Director for Pediatric Infection Prevention and Control at Norton Children's Hospital. She's a member of the leadership team that coordinates infection prevention and control efforts at Norton Healthcare in Louisville, Kentucky, and a professor of pediatrics at the University of Louisville School of Medicine. She is the current president of the Pediatric Infectious Diseases Society Board of Directors and a co-editor of the Handbook of Pediatric Infection Prevention and Control. Since December of 2016, she has served as a member of the Healthcare Infection Control Practices Advisory Committee, HICPAC, a federal advisory committee appointed to provide advice and guidance to the CDC regarding the practice of infection control and strategies for surveillance, prevention, and control of healthcare-related infections, antimicrobial resistance, and related events in the United States healthcare settings. Dr. Bryant's research interests include the prevention of device-associated infections, including dialysis-related infections and vaccine clinical trials. Welcome, Dr. Bryant. Our second panelist is Dr. Lori Caloia. Dr. Caloia received her medical degree from Michigan State in 2004, following a transitional internship at San Antonio Uniformed Services Health Education Consortium. She served in the U.S. Air Force as a flight surgeon for 5 years and was responsible for oversight of base-wide public health programs. She completed her family medicine residency at Virginia Commonwealth University, Fairfax Family Practice, and a leadership certificate in public health at Eastern Virginia Medical School in 2013. She will complete her master's in public health this month, and she is currently a board-certified family medicine provider. From 2013 to 16, she was an assistant professor in family medicine at the University of Louisville, and then a primary care provider at Norton Community Medical Associates from 2016 to 17. Since November of 2017, she's been the medical director at the Louisville Metro Department of Public Health and Wellness, with oversight of clinical services and communicable diseases, including outbreak and pandemic response. So welcome, Dr. Caloia and Dr. Bryant, and we look forward to hearing what you have to say.
Thanks so much, Dr. Boland. While I am working on sharing my screen, I just want to really thank Dr. Caloia for being with us today, for making time to be here to answer the questions of the audience. And really, I think we all owe her a major debt of gratitude for her tireless efforts to support the community during the pandemic, support the medical community. I know I have had Dr. Caloia on speed dial and have reached out to her at all hours of the night and day. And so she has done an amazing job, as has her team. So thank you, Lori, for being here today and for all of your efforts. It is nice to see so many familiar names in the list of participants. During the height of the pandemic, we were chatting regularly, once a week. And then it seemed like things had really settled down, and we sort of moved into a new normal, and we gave up meeting weekly. So I have heard from some of you individually, and there was a request from the community to come together and talk about schools and daycares. A couple of disclosures. We're going to talk mainly about schools today. We'll talk briefly about daycares at the end. I am not going to try to wow you with a lot of slides today. In fact, I just have just a couple of slides, and then Dr. Caloia and I are really going to have a Q&A kind of format. I encourage you to type your questions in the Q&A. Dr. Boland will be moderating that, chiming in with questions. I also encourage you to share your experiences in the chat box. Let us know what's happening with you and your patients and your families if you want to let us know that. All right, so let's jump in with just a few introductory remarks about school. Worldwide, 1.5 billion kids stayed home from school this year as a part of their response to the pandemic. Schools closed in the US in all 50 states in March of 2020. And public health experts, researchers think there was an impact. Some of you have seen this article published in JAMA within the last week. It's a modeling study that looked at the impact of school closures in states that had very little COVID transmission. That's the top left, the lowest quartile, all the way up to the highest quartile. We could spend a long time talking about these elegant graphs, but I'm just going to give you the punchline. According to this modeling study, it is estimated that school closures may have been associated with 1.37 million fewer cases of COVID-19 over a 26-day period, and potentially 40,000 fewer deaths over a 16-day period. Why do I have all of those caveats? It's a modeling study, and in every state where schools closed, which is every state, lots of other things were happening at the same time, right? Workplaces were shut down, restaurants, bars, all but essential businesses. Parents didn't go to work. They were at home with their kids. And so there were, this study tried to account for that, but it's really difficult to tease out school closures as a single intervention. All right, so as pediatricians and as other experts who care for children, I recognize that we have a diverse group on this call today. I don't think I need to convince you of the importance of in-person school. I think many will agree that virtual learning was effective for some, but it wasn't uniformly successful for all children. Not all children have access to the internet. Not all children have parents at home to help guide their studies. There were a number of potential adverse effects that have been proposed. And so, McKenna, if we could have the first polling question, please. Have you seen or have you observed negative effects, including but not limited to behavioral or emotional problems in children, food insecurity, lack of access to medically necessary therapies in your patients because of school closures during the pandemic? Please just check yes or no. And McKenna, when you think that everybody's had an opportunity to vote, I'm sure you'll show us the answers. All right, so I see that the majority of you who voted have seen at least some ill effects of the pandemic. School is not just a place to go to learn, it's a place where children go to learn social skills, to learn teamwork, to learn how to interact with other children and with adults. Some children depend on the food they get at school to not be hungry. Some children are reliant on school to have access to behavioral therapies, physical and occupational therapies, and there's at least some signal that cases of child abuse went up with children being at home and no adults at school who were noticing early signs of abuse and reporting it. So it's important to open schools. We need to do it safely. There are a couple of concepts that I just want to touch on when we talk about school opening. One is children and susceptibility to infection. Multiple studies, but not all studies, have demonstrated that children are less susceptible to infection. The bottom 4 studies on this slide looked at secondary attack rates in children and adults, and you can see that 4 of the 5 suggested that children were potentially a half to a third as susceptible to COVID-19 after exposure. Another concept that we need to talk about is how likely children are to transmit to others. There was a big paper that was recently published in Emerging Infectious Diseases. It traced more than 59,000 contacts of more than 5,700 coronavirus cases in South Korea. And the headline said, wow, children are as likely to transmit novel coronavirus as adults. That's not exactly what the study said. So what did it show? Contact tracing suggested that young children are not very likely to transmit infection. So when they looked at household contacts of children 0 to 9 years of age who were identified as index cases, so the first case in a family, only 5% of their household contacts were positive. Now in older children, those 10 and above, nearly 19% of their household contacts were positive, and this was very similar to adult transmission rates. The good news is children of either age group were really unlikely to transmit to non-household contacts. Admittedly, this was during a time in South Korea when schools were closed. All right, so early on in the pandemic, I think I presented some slides to this group that suggested that children didn't get infected very often. The initial studies from China suggested that children were maybe 1% of all reported cases. Low numbers from Italy as well. Initial data from the CDC suggested that children made up 2% of cases in the US. So it did seem that children were not getting infected in the same numbers as adults. Before we start the Q&A with Dr. Caloia, I just want to share some updated data. This is a website that Dr. Caloia shared with me. It's a updated look at COVID-19 in Jefferson County. You can see our total number of cases, total recovered. If you click through the links on this slide, you'll be able to see the trajectory of transmission in our community. Maybe the last week we've plateaued. In the 3 weeks prior to that, there was a steady upward trend. If we look nationally, it's no longer true that children make up only 1% of all cases. Children now make up about 8% of all cases, almost 9% of all cases reported nationally. There have been more than 340,000 cases in children. A number of states have reported increases, including Kentucky. In Kentucky, children make up 11% of all cases of COVID-19. Within Norton Healthcare, our numbers are pretty consistent. We have had 346 positive tests in kids under 18 out of about 3,047 cases. I think we are really still learning about the epidemiology of this disease in children. Fortunately, most children do not get hospitalized, and mortalities are quite rare. All right, so with that brief introduction, I'd like to talk about how we reopen schools safely. Many countries have done it successfully. This is a picture from the Netherlands. You see children in little plexiglass enclosures surrounding their desk. There's not a one-size-fits-all approach. Some countries have done it well, and then I think if you've been watching the news, you heard about big school outbreaks in Israel. Schools opened, they didn't reduce class sizes, they had a heat wave, they told students not to wear masks, and they had big outbreaks. And so to some extent, there's not a one-size-fits-all approach. We really need a community-driven approach, and that's why I am so happy that we have Dr. Caloia here today. So I am going to stop screen sharing and welcome Dr. Caloia.
Thank you.
All right, so as we are settling in, McKenna, let's go to the second polling question. The real impetus for this question was some of the questions that I've been receiving from the audience. When parents in my practice talk or ask my opinion about whether or not kids should return to in-person school, I say, if schools are open, your child should return. Even if school's open, I don't think it's safe. In-person school is fine for most kids, but if your child has an underlying healthcare condition, virtual is safer. And then finally, I hate this question. Who even knows what to say to parents these days? Please vote. I wish we were all in a room together where we could have a group discussion. And so the polling questions and the Q&A and the chat are really an opportunity or an attempt to make this into a discussion and not a didactic presentation. So thanks for playing. I think the answers, Lori, I don't know what you think, but I think option 3 is, I am pleased that most people are saying school is fine for most kids. At the end of the presentation, I'll show you some information that Dr. Victoria Statler developed with colleagues at children's hospitals across the country about children with solid organ transplant patients and how to approach school opening for them. But I think it's remarkable that more than a third say, I hate this question. So, Lori, my first question for you is, schools are out and kids are getting infected. Where, how are they getting infected? And do we know?
Yeah, I think a lot of the data that we have relating to many of the most recent cases is still preliminary. However, I think we've seen several trends. I think our website would reflect this as well. By far, what we have seen is that the primary source of transmission in kids has been within the household. So perhaps a parent through their employment or some other exposure has brought it into the household. but that is by far the number one source of spread within, or of spread we've seen with children. So sporadically, we have also seen, as daycares have opened and athletic events have occurred within the city, those have become more and more available to kids and families. And we certainly have seen sporadic cases and even a few clusters coming out of those events. So, you know, obviously that's a warning flag to say that these things are certainly not without risk as we reopen. But I think from a generality, we are still seeing substantial spread within households. I will say that many of these facilities, and I know the athletic director at JCPS, from my conversations with their health director, have been having, you know, ongoing planning, really trying to prevent things from happening, and then knowing, you know, as soon as they have any concern at all, you know, having a very low threshold for shutting things off, canceling practices until they know for sure what to do next. So so I will say that although we have seen cases, I think because these types of events or facilities are well prepared, that they're reacting quickly in order to prevent substantial spread among the kids themselves.
Yeah, so thank you. You know, I think it's, from my standpoint, it's important to kind of frame the conversation about school opening. If school closures were potentially really effective early on, because when schools closed, kids and parents stayed home. But right now, schools aren't open and kids and parents aren't staying home. And if schools don't open in the fall, it's hard to know if that would be any different. So let's talk for a minute about what happens when a case is identified. Can you walk our audience through that?
Sure. I think we have two real reporting mechanisms at the health department. So what we see is either lab reporting, which is where we get an electronic lab report through an electronic database system, or we may also get a fax from a lab just reporting a positive result from a COVID case. And I'm going to go very specifically with COVID here, although a lot of this applies for other communicable diseases. On the other arm of that, we also get a case report or a clinical report. So those are two separate processes. Those are both required. So as a provider, by law, you're required to report these cases to us as well as the lab reporting. And those are different because the lab report is really just that. It is a snapshot. It tells us a result. It does not tell us anything else about the case. And so the clinical reporting really gives us more information about the case and helps us determine if it is truly a case, or where, you know, as much information as we can about the specifics of that individual. Part of both of those that's really important is the actual contact information that's included, because we only have that information to go on in order to try to get in touch with a patient or a family in the case of a kid. And so reliable contact information is very important. Many of our case investigations are delayed or even impossible if we don't have accurate information. So once we receive either the lab or the contact or the case report from the provider, we then open a case and then we do a case investigation. So the details that are typically provided on the PUI or patient under investigation form, those details, if we don't have all of them, we go back and try to complete that information as much as possible, determine where the individual may have acquired the infection, and then we try to identify where they have been and what contacts they may have been in touch with. And we get that all entered into a single system. And then the contact tracing team, you've probably seen or heard about this if you've watched the news lately or checked out our website. And Lacuna Health is helping with our contact tracing. And so they are taking those contacts from the case and running down and trying to get in touch with all of them to let them know they've been a contact of the case and to discuss with them the quarantine recommendations. For the case itself, once they're identified, we also have a team through Lacuna who is reaching out to do daily case calling to check in on them, make sure that they're not becoming more ill, that they would need to have a higher level of care, and then also trying to help release those individuals from isolation as soon as possible based on symptom-based criteria that have been provided by the state and the CDC. So I think one of the biggest delays that we're seeing right now is with both case reporting and lab reporting in general. From the lab perspective, the biggest delay really is in the rapidity with which the labs are able to do the test. So a lot of the national labs, I'm sure you all are aware, can take a long time to get a result out to us. And so if you're receiving the result as a clinician, it may be 2 or 3 days later when we actually receive that result. So one thing I would say in this whole process is that we can now make a probable or suspected case definition with a clinical case report. And so I would encourage you all not to wait until you get a result from a lab test back, but if you really think that you have a patient with COVID-19, that you should complete the EPI 200 form that's on the state's website, and then also that PUI form to the best of your ability and forward that on to us so that we can go ahead and start to initiate the investigation while we're waiting for those delayed test reports to come back.
Thank you. Now, I have gotten a lot of questions about the time to self-isolate or quarantine. And it's a little counterintuitive. If you're a case, whether or not you have symptoms or you just have a positive test, you have to self-isolate for at least 10 days from onset of symptoms and positive test. But if you're just an exposed person, it's longer.
Exactly. And I think that continues to be a major point of contention. So we are really focused on the symptom-based return to work or to school and release from isolation, particularly with some of the testing shortages and delays that we've seen. More data that's coming out is pointing towards that being a safe way to release people from isolation. So I would certainly encourage all the providers to be sharing that with your patients. And that is 10 days. And now the duration of symptom resolution of fever, that has been reduced from 72 hours to 24 hours. The state sent out something yesterday, so we should have something posted on our website soon on that. But then I think the really confusing part is, we're having sick people only stay home for 10 days, but when you've been a contact to someone who's a case, we're telling you that you need to stay home for 14 days. And one thing that parents really want is for us to do a test and then tell them that their child can now go back to school or daycare and that they don't need to self-quarantine for those 14 days. But, a test done today on someone exposed yesterday is probably going to be negative, and we might do that test 3 more days in a row, and it won't be until that 4th or 5th day that they end up testing positive. So that guidance has not changed since the beginning of the pandemic, and I don't see that that's going to change in the near future, just because we do know that there's a percentage of people that will end up developing symptoms or testing positive within that 14-day window. So that's really that discrepancy. And I think one thing that pediatricians and other healthcare providers can really help with is helping to provide that piece of education to families, because that has definitely been a pressure. I think daycares are getting, and schools will be getting those questions or concerns from parents wanting their kid to go back, but not understanding that that is the recommendation.
Dr. Boland, I think you may have a question from the audience about schools that touches this subject.
Yes. There was a question in the Q&A that I thought I'd go ahead and jump in because it seems pertinent right now. Has JCPS been utilizing your all's expertise and your information to make decisions. They seem to have so many large barriers, such as space to distance, lack of resources, union protecting teachers. It seems like they may not open without lots of planning and pushing from the experts.
Yeah, that's an excellent question. I will say the state has really tried to lead the charge, providing the schools with a lot of information. So the Kentucky Department for Education has been having ongoing webinars with the school system. So any school in the state would have access to those resources, and really trying to provide the guidance to make sure that they know what to do to open schools safely. One of the challenges, if any of you have been looking at some of the guidance, is that this is really hard to do in reality. It looks great on paper from a public health perspective. It makes perfect sense, but implementing those safety measures is really a challenge. So I know from the beginning, JCPS in particular has implemented a school reopening task force, and they've been meeting regularly. I have had ongoing conversations with their district health manager, trying to make sure that they have those, one-off questions or other things that might be unique to JCPS or to certain schools within JCPS answered as they go. So I would say I don't think that schools being delayed in opening is based on any lack of effort on their part. And I'll also say that, it's a challenge even just as an organization from an employer perspective to try to open an employer or a business as large as JCPS. And so adding schools on top of that, it seems almost an insurmountable task for them from my perspective. So, I'm hoping that they can pull it off and do this successfully. But as you can imagine, there's a lot of challenges with that.
Great, thank you. One other question just came up on the chat that I think is pertinent to questions you were just talking about testing. What day after exposure is the best day to get tested, or is there a day?
So that's a great question. I think my ongoing recommendation is that if you've been exposed, the best day to get tested is if you develop symptoms, because really you can end up testing positive anywhere from day 2 to day 14, and in some very, very rare cases beyond day 14. If you're looking to try to provide, family member or patient with the best recommendation, if they're really adamant about getting tested, I would look at the kind of sweet spot to me would be the middle of the road. So between day 5 and 10, understanding that, the majority of cases will be test positive by that day 10, but that there's still a portion of people that that will test positive beyond that. And then also really making sure that you're providing that recommendation to families and parents that, even if your kid or you test positive or test negative, that does not mean that you are now released from quarantine.
Right. Great, thank you. We actually have one more question that I think is going to lead into some of the stuff you're hitting next, both of you. So I'm going to go ahead and read it out so that you can make sure you get the answers in what you're next addressing. This practitioner actually practices in Indiana, and they've already had some school systems open. And so do they have any recommendations about the symptoms or set of symptoms which would exclude a child from school for the whole 10 days versus some alternative diagnosis like the flu or rhinovirus or, any number of other enterovirus? And a negative test alone obviously doesn't clear the student to go back to school per the health department, as you were saying. So how might you address some of those other issues?
Yeah, I think this is a real challenge. And, I think Dr. Bryant and I have talked about this a lot and frequently. And I think one thing is really kind of keeping in mind that pretest probability, right? Right now we're not seeing a lot of other respiratory diseases. I think so at this point it's a little bit easier than as flu comes on and the other respiratory viruses start to become a lot more frequent in the community. And we have a lot broader differential diagnosis. But from our perspective, I think really, the CDC has continued to update their guidance on what symptoms to look for. So I would keep looking there. I think we're probably at the far end of that. And I'll let Dr. Bryant talk a little bit more about, what maybe they've been seeing in the hospital from the pediatric infectious disease, or what she's been hearing from other colleagues. But I would really look at your pretest probability. What is the likelihood that this is COVID based on the symptoms, based on exposure? So has the child been around someone with COVID-19? And if that's the case, then, if they have even one symptom and they have been exposed to someone with COVID-19, then that is probably going to meet a case definition from the public health perspective. And then we do have very clear case definition criteria that the state has issued. I don't know how easy that is to find on their website, but they, so, based on from our perspective, the case definition is a public health case definition. It's not a clinical definition, but that may help you to really try to make better decisions about who is safe or should or shouldn't be sent back to school. I think the other thing is, with testing, you might have a kid that has a fever, you've looked for strep throat, their test is negative, you really have ruled out a lot of other possibilities, and they end up having a negative COVID test, or you're waiting on the results. I think, what we've realized is that it would be great to have, point of care rapid tests available, so that we could say, what, they tested negative today. If they continue to remain sick, we may want to retest them. And if we could get those results rapidly, we'd be able to make a better decision. We don't have those capacities broadly available right now. So I think that makes this an even bigger challenge. And Dr. Bryant, I'm going to have you kind of answer some of what you've seen, and see if maybe you have an approach from the more clinical perspective. I have a very rigid, case definition, public health perspective, but I know it's often not that simple clinically.
Well, that was a great outline of what the challenges are and the case definition versus the clinical definition. I think what we're seeing in the hospital and in the community is that this virus looks like every other virus in children. It can cause a runny nose and a little bit of fever. It can, we've seen febrile infants who get admitted for an evaluation for sepsis, and they have COVID. We've seen kids who had primarily vomiting and diarrhea. We've seen some kids who had fever and a rash, or fever and mouth sores. And so it looks like every other virus. And so in my ideal world, we'd have a rapid test. Full disclosure to the audience, Dr. Caloia and I have this conversation at least once a week, and as often as she can stand me bugging her with this. We'd have a rapid test. We'd say, okay, it's negative. We believe your test. And when your fever's gone and your symptoms are better and your diarrhea is resolved, you can go back to school. The challenge is now, and then we could have a low threshold. We could test everybody who had any symptom, from runny nose and a little bit of fever to cough, shortness of breath, sort of typical COVID that we see in adults. But we don't. That's one of the practical challenges. So it's really hard for pediatric providers to tell by looking. I think some of the schools and daycares, primarily daycares at this point, want pediatricians to certify that a kid doesn't have COVID to let them return. And so I wonder if there are some, practical guardrails around this. So I'll throw a couple of scenarios out, and maybe the audience will give us some. If you are an exposed person and you have any symptom on the list, even if it's mild, you probably either need to be tested for COVID, and even if your COVID test is negative, but you're sick and you're an exposed person, you're home from school. If you're a 4-year-old who has headache and belly pain and a sore throat and you have strep, you probably just have strep. Mm-hmm. And so maybe you don't even need a test for COVID unless you're an exposed person. If you are a kid who has fever and otitis or cellulitis or another clear reason for your fever, you probably don't need to be tested for COVID, and you can go back. But if you're a kid with fever and cough, and there's no other reason, maybe you're a kid with asthma who presents with an asthma exacerbation, and the pediatrician's or pediatric care provider's impression is viral exacerbation. You need a test, or you just need to stay home. What do we do when the tests are taking 10 to 14 days to come back? Do we really just tell parents, I think your kid has COVID, you all need to quarantine? Is that what, Dr. Caloia, is that kind of the, I feel pediatricians going, oh no.
Yeah. No, I think that's at least a good framework to put this in. And I do hope that people provide some input in the chat box as well, and perhaps bring up some other scenarios, because I know there's a lot of challenging scenarios. And, you know, I think you said it very well as far as if you've got someone even with, you know, minimal symptoms, but they've been a contact to a case, that actually meets our case definition from a public health perspective. So that kind of simplifies the recommendations for that. And that would be to, you know, go by that symptom-based criteria, the 10-day exclusion from school. And then again, going back to, is there another more likely explanation for those symptoms? And, you know, do they resolve with the expected treatment for whatever that other more likely explanation is? So they take the antibiotics for strep and they start getting better within a few days. You know, certainly from a clinical perspective, I think that the pediatrician can safely say in those cases, you know, this is the appropriate action. And then I think, you know, in the case where you're really uncertain but don't have a high suspicion for COVID-19, you know, I would continue to apply what we tend to apply across the board is, you know, those common sense pediatric ideas of, you know, if your kid is getting better, they've been afebrile for at least 24 hours or perhaps longer if your threshold maybe is a little bit higher than that in your level of concern for this kiddo and what other things you might have on your differential. But I think what we've really seen, I think, in some of the evidence is that as those symptoms do resolve and the fever goes away, that the infectivity tends to also become less or non-existent with COVID-19. So even if you're just applying kind of those standard rules to every case, I think you're going to be keeping the majority of kids out of school that shouldn't be in school, and probably not sending a lot of kids back to school that shouldn't be there. And then I also think the, you know, really emphasizing with parents, and I know that you already do this, that afebrile means without anything that will lower the fever. So they can't be sending their kids back to school on Tylenol and ibuprofen just so that they can get them out the door because they're driving them crazy after too many days home in a row. But and I know you all do that, so I'm not too worried about that. But I do think that that is a huge point to emphasize with parents, that this isn't a time where we want you to skirt the rules. We need to be as, you know, as strict as we can from that perspective, because I do think that that absence of fever makes a big difference in these scenarios.
Can anybody go back to school with a pending COVID test? Let's say the pediatrician said, could be COVID, sent the test, it's day 6, 7, still no test result.
So I think from that perspective, those would be cases just from a clinical standpoint that, you know, I would recommend following more closely and perhaps having a nurse or medical assistant reaching back out to the family, checking in to see how the children are doing. And those may also be cases where, you know, that you might make a call to the provider hotline at the state, or even retesting in some of those scenarios, which doesn't do you a whole lot of good if we don't have the results back. But I think there will end up still continuing to be cases that fall into that category of concern. And I don't know that there's a fabulous solution to that at this point until we are able to get more of those rapid tests available.
Yeah, so we have a polling question that relates to testing. We actually have 2 polling questions. McKenna, can you pull up the next polling question? All right, I have access to COVID testing that will result in 72 hours or less. Tell us about your world right now. You can see host and panelist can't vote, but if I had to answer this question today, I would say no. McKenna, what does the audience say? Most people not. Okay. All right. The next question then is, McKenna, if you'll pull up that one, please. In the absence of clinical testing, I am comfortable making a clinical diagnosis of COVID. The questions are getting harder as we go along. And so 97% say they are not comfortable making a clinical diagnosis of COVID. And I think that's one of our real world challenges, is that it looks so much like everything else that we see. And I've been fooled. Dr. Boland may want to chime in. Her experience, she's seen COVID patients, and we've talked, the ones that we thought were going to have it have negative test, and especially the early positives were the last kids we would have thought about it. So
yeah, we the first couple patients that I saw with it, one came in, we thought for sure it was a real out appendicitis, then GE, and there was another one that was a post-op TNA who ended up having comorbidities, and she had other she had HSV stomatitis, but she also had COVID. So it makes it really hard to rule, even when you have other things present. Sometimes it's challenging to rule out COVID too. And we just tested her on suspicion and she was positive. And she had a few other little subtle things that made us think that that might be what's going on, but it is a challenge.
Dr. Boland, do you have questions from the chat? Oh, sorry.
I do. A quick one I can handle is, has COVID been found to cause croup? I have not heard one way or the other on that. Have you?
I have not. Have you, Dr. Caloia?
I have not heard it specifically causing croup, but like you said, Dr. Bryant, I feel like that wouldn't be, that would probably be par for the course as far as the variability of symptoms in kids.
Yeah, and I wouldn't rule out that croup is present as well as COVID. So you could have multi-infections. Another question was, do you know if or when Kentucky plans to release a specific COVID return to school guideline for physicians to follow?
So
we're all anxiously waiting for that to come.
Yeah, this is a great question. And I don't know that they're ever going to issue a return to school guideline specifically, but the state did just release yesterday, as a matter of fact, and should be updated on our website by next week, the guidelines for return to school and work and even congregate settings. So they have divided a lot of the recommendations into those with mild to moderate illness, and then those with severe illness or immune compromise. And so I guess just be on the lookout for either our website or the state's website. And then I'm also happy to share that with the CME team if there's a way to provide that to the audience after this as well. I tend to get those things hot off the presses. So there's definitely those case definitions, and then the release from both isolation and quarantine in those situations.
Great. can you talk a little bit about what constitutes an exposure in a school setting? Same classroom, same bus, they pass by in the hallway for a couple seconds, you know?
Yeah, so that's a great question too. And what constitutes an exposure in any setting is the same as in schools. And so for Jefferson County, we have used a fairly conservative approach, 6 feet, within 6 feet of an individual for 10 minutes or longer. There's been some variability to that. I think right now you'll see on the CDC's website 15 minutes with a couple of asterisks that say, you know, this might change based on the actual exposure. So we really take things case by case. But and then I think the caveats to that are you could be in a room with someone for 10 hours and be 10 feet away from them and potentially still end up breathing in their aerosolized particles. And likewise, you might be within 1 foot of someone for less than a minute, but if they sneeze in your face, you're probably going to, be at high risk for exposure. So there is some nuances, but we are really trying to stick with that 6 feet for 10 minutes or longer. And then one of the things that we're asked frequently is, what do masks have to do with that? And I think one of the limitations in the school setting is it's really hard to be able to get a good assessment at how well the child or their contacts were wearing a mask. And so, if it's an adult and we can get a good history from a disease investigation standpoint, then we tend to find that pretty reliable. But for kids, if especially in younger kids, we're probably going to be more conservative and identify contacts that maybe weren't true contacts, but if we can't make a true determination, we'd rather notify them that there's a possibility that they've been exposed than have them think that they haven't been exposed and spread this to someone else unknowingly.
Great. A couple more questions, I think, but I know you guys might want to have a few closing points. So let me get a couple of these questions out, and then I think maybe we can get some answers out to everybody afterwards if we need to. I think this is a good one. What's our responsibility as pediatricians to write notes or provide guidance for parents to be home from work with children who've had COVID symptoms, but a negative test or no test at all? And I think that's going to be a challenge for a lot of us.
So I think, yeah, definitely. From our perspective, if we have a known case, we at the health department, unlike most other communicable diseases where the pediatrician is typically writing these notes, when we have quarantined or isolated someone, we are typically providing them with a documentation from the health department. So they would have that for their employer or for the school to provide. And I will go back to the original statement I had that, someone can qualify as a suspected case of COVID-19 even without having a test or having a negative test. They can still fall within the case definition. And so, I would encourage you, and I will again happily share the case classification from the state health department after this as well. But I would encourage you just to look at that to see what are we defining as those things? And in those cases, I would say certainly, that would be really helpful to the health department for you to provide those things while they're waiting to get into our queue, or if we're waiting for a test result to come in. And certainly for those cases that you realize, oh boy, these are actually cases maybe I should have been reporting before this, even though we didn't have a test result. Feel free to forward those on to us. The sooner we get those, the sooner we can create those cases and then help with that documentation on our end.
So, Dr. Boland, as I glance at the questions, there's a question that came up in the Q&A that was on our list. If a child has a fever and a runny nose and a cough and they don't want a COVID test, how long do they need to stay home? And I think, this is going to get pertinent as we don't have tests. Dr. Boland, you're on mute, I think.
That was the one I was getting ready to read. So
okay, all right. So Dr. Caloia, can refusing a test get you back to school quicker?
I would say no. And again, going back to that case definition piece, and then also again, that probability. So, if we know this child's been a contact to a case right now, I would say they're already a case. And so, they definitely need to stay home from school. And then, I understand a lot of parents probably don't want their children to have a nasopharyngeal swab just because it's not a fun thing for anybody. And so, I would imagine you would have a lot of those scenarios. And I think some of this will be up to the schools as well and their ability to allow someone in. And then again, your clinical estimation of whether you think this is COVID or something else. But even with, a negative test, could it be that this person still has COVID, and is that really going to change your mind on whether or not you should keep them home from school? So don't underestimate your clinical acumen in these scenarios.
Dr. Caloia, some states, Oregon comes to mind, they have metrics. So a certain positivity rate or number of positive cases per 100,000 prompts a school to open, or prompts school opening or school closures. Do we have such metrics?
So we have not developed specific metrics for school closure. And I will say that a lot of what I have seen is based on pandemic flu modeling, and also what has occurred in previous pandemic flu responses. And so there's definitely science behind this, but a lot of it is theoretical. And so we suspect that if you have moderate to severe spread in the community, that it's probably a bad idea to open schools, or that you should have a very low threshold to close schools when you have additional cases. And there's also other considerations that we look at from a public health perspective. So what is the absenteeism rate throughout the schools? The higher it is, the more likely it would be to make a recommendation for school closure. Number of cases within a classroom or within a school is also another consideration. And then, I think for us, we really try to do things more case by case in general with other illnesses. And so we would look at, do we shut down a classroom? Do we shut down a grade or a school or the whole district? And again, that kind of goes back to what's the community spread. And, some of the pandemic flu modeling really shows that, shutting down school districts as a whole does help to reduce community spread a lot more than shutting down piecemeal. So there may be some utility to doing that in order to not have prolonged or recurrent shutdowns throughout the city. But, unfortunately, we're in uncharted territory. And so I think we'll be learning together what the best methodology to do this is with COVID-19. And then the other challenge is flu is a lot shorter duration. And so the shutdowns we would be looking at would be probably 3 weeks or longer. And so, I think that makes it really difficult to say, boy, are we just going to shut down for 3 weeks every time that we start to see this rise? And so I would love for there to be a better way to do this. But at this point, it's going to be case by case, and then really making that community-wide decision. And then I suspect there will also be some state and Kentucky Department for Health recommendations along with that as well as we go along.
Thank you. I'm going to, we have so many good questions in the chat. I'm sorry that we are coming to the end of the hour. Let's see. All right. I just want to make everybody aware of this fabulous resource developed by Dr. Statler and her colleagues, FAQs regarding return to school for children after solid organ transplant. Now, I recognize that many of you don't care for a lot of children who have solid organ transplants. But the principles, I think, could be applied to other at-risk children. They address what to do with siblings, how to think about risk. And I'll tell you that we have counseled many of our solid organ transplant patients who are on sort of baseline immunosuppression. If rates are controlled in a community and your child goes to a school that has a good plan and your child can comply, that your child can probably go to school, but it is a family decision. We didn't really, school is such a big topic. We didn't have time to talk about that today, or to talk about daycares, but this is an image from the YMCA in Arizona. As Dr. Caloia mentioned, there have not been a lot of daycare cases. Many YMCA daycares stayed open during the pandemic to care for the children of frontline healthcare workers. YMCAs cared for more than 47,000 children in more than 1,000 sites, and they really didn't have clusters or outbreaks. They had some sporadic cases. Several of us, including Dr. Carruthers, Dr. Caloia, have been working with the state to develop FAQs. Those are with the governor. I don't know when we're going to get them. When some of you have reached out and said, tell us what our plan for daycares is, my response has been, it's really not up to me, it's up to the health department. But we don't want everybody to call Dr. Caloia with every kid in a daycare who gets a fever. So hopefully these will be coming this week. As we close, I want to thank Dr. Caloia again for taking time from her very busy schedule. And Lori, I want to give you the last word. So what do we need to do to open as a community to get to the point where we say, yes, we feel good about schools opening?
Yeah, I think I would just like to say thank you to all of you who are on the front line as I'm working behind closed public health department doors, trying to help with this community-wide planning and response. I realize that a lot of you are facing these unanswered questions from patients and parents, and it has definitely been a learning event for all of us these past 5 months. So thank you for your ongoing efforts. We appreciate you here at the health department. And I would say, I think the main tenets that I really try to reinforce with the schools and we're trying to keep the community out there to understand these things is that if we do implement social distancing and everybody is wearing a mask, there is substantial ability for us to control this without having to keep everything shut down. And so really encouraging patients, parents to heed those recommendations. And even though it's difficult and it's not necessarily fun, it is certainly something that I think we're seeing in other countries and we're starting to learn here that's absolutely essential in order to be able to try to return to some sense of normalcy in our community. So that's all. I think I would end on that.
Well, thank you so much. Dr. Boland, do you want to wrap it up?
Sure, great. Thanks, Chris, and thank you, Dr. Caloia. I really want to thank everybody for joining in. There's still a number of questions, so what we're going to do is copy these questions over, get them to Dr. Bryant and Dr. Caloia to get some answers to, and then we will send an FAQ out to everyone who was part of this seminar session, so thank you very much. So your questions will get answered to the best of our experts' ability right now. Also, I just want a reminder to evaluate this for your CME credit. In addition to an email, when you exit the webinar, you will be linked to a SurveyMonkey and you can hit the continue button and that will get you to the evaluation for credit. Thank you very much for joining us. Have a great week, and I hope you join us at August 19th for Josh Meyer talking about common sports injuries. Thanks, everybody.